of next week's National Healthcare Decisions Day and hope you will find the topic timely and pertinent, both personally and professionally. It is an honor to have Dr. Alex Nesbitt as our presenter. Dr. Nesbitt is Medical Director of Susquehanna Hospice and Palliative Care. He is board certified in family practice, geriatrics, and hospice and palliative medicine. After 20 years of active primary care practice, he has worked full-time in hospice and palliative care since 2006. He is chairman of the Medical Ethics Committee at Susquehanna Health and chairman of the North Central Pennsylvania Advanced Care Planning Task Force. Dr. Nesbitt led a region-wide advanced care planning process implementing use of the POLST form in Lycoming County beginning in 2006 and has been a part of this statewide effort to facilitate the POLST form throughout the state of Pennsylvania. He is a frequent speaker to professional and community groups locally and around the state on topics related to advanced care planning and end-of-life issues. Hello, Dr. Nesbitt, and thank you for this presentation today.
Well, thanks, Marian, and thanks to everybody who has decided to spend an hour this morning talk about the topics of advanced directives, advanced care planning, and the POLST. Really, what I want to do in the next 45 minutes or so as I talk, I want to spend some time looking at the documents that we use, the traditional advanced directives, the paper that we use, and history of the different things that we've done in that way. What doesn't? What are the benefits of different advanced directives, and what are the limitations of them? And then I talk a bit about the even more important thing, and that is the process of advanced care planning, not just filling out papers, but really thinking about what's most important for this person. What are the key things in their life? What makes life worth doing? And what sort of interventions would fit for that? And finally, talk about the POLST form, which is a specific form for a specific population where we need to make real sure that we get it right. Well, really important thing, and what makes it important is that all of us have people like this guy who depend on us to get this right, to do the right thing. They count on the fact, our patients and families, that when they get sick and they show up at the hospital, they'll do the right thing and not do the wrong thing. So I'll call him Fred. Fred's a 72-year-old man, a retired business person, and he retired. He loves to fish, so he is a fisher guy, and he had just gotten back from a fishing trip when we took this picture. Unfortunately, a couple days later, a really big middle cerebral artery stroke and was found face down at home by his son. From the hospital. He had testing at the hospital that showed that he had had a really large stroke. He was unable to speak or swallow. He was deeply lethargic, not really interacting at all with those around him. And fifth day in the hospital, and with decisions to make about Fred. What to do for him? What's the right thing? At night, Fred aspirates on his secretions, which he's just not managing very well, and into respiratory failure. Should we put him on a vent? If he goes ventricular fibrillation, should we shock him? Should we do CPR? What about tomorrow? He's not safely swallowing now. Should we tomorrow or the next day put in a feeding tube for him? Or should we not? What's the right thing for Fred? We would know the right thing if Fred could magically shake off his stroke for 10 minutes and sit up in bed and hear the information about how it is and what we expect, and then tell us what we should do. Then we would know. Very often, almost when somebody is this sick, they're too sick to be able to tell you at that moment. Count on us to get it right. So how do we get it right for Fred? How do we know what to do? Our country, our health system, our approach to this, and by our health system I mean we Americans, have come up with several answers to how do we create a system to make sure that we get this right. Fred's that we care for? The first answer to this question was the Living Will document. So Living Will started 40 years ago or so and originated with some prominent legal cases like Karen Ann Quinlan and Nancy Cruzan and others that were very prominent in the consciousness of the country and really focused on the ability of individuals to decline or stop treatment that they did not want. Focus in this phase of how we solve this dilemma of getting this right was very much on the document. It's really important to fill out this paperwork. The paper was a legally focused paper, always done in attorneys' offices. And the patient would specify, what things do I want? The focus was on situations like, if I am terminally ill or if I am in a permanent state of unconsciousness, I want or do not want, and then there was a list of different things. Ventilators, CPR, dialysis, antibiotics. And the main focus was on the individual and the individual's autonomous right to define what they want and have it legally enforced. Well, unfortunately, the promise, the hope for the living will paradigm, that if we do this, it seems such a great idea. If we have everybody just fill out their living will, know what to do. When they become Fred and they're so bad, then we'll just look at the paper and we'll know. Fortunately, the living will paradigm has failed to meet what we all hoped it would do. Now, saying the living will paradigm has failed is a little bit controversial. You can't say living will isn't okay. Everybody knows living will is a good thing. Well, why say that? Well, first of all, most don't do them. Despite 4 decades of a full court press all across the country to encourage people to do their living will or advance directive. There's way more than $100 million spent promoting this, encouraging people to do this. It's been widely endorsed, living will or advance directives, by name and organization, all major medical organizations, the American Medical Association, nurse associations, legal organizations, AARP, State Medical Society. Everybody knows the living will is really a good thing. Americans have gotten that message, so in surveys, when people are asked, is it a good thing to do a living will? Do you think living wills are a good thing? Way 90% of people say, absolutely. Oh yeah, it's really good. It's really important to do it. It has been the law, federal law, since 1990. The Self-Determination Act required that every patient that's admitted to any hospital or any nursing home must be asked, do you have an advance directive? And would help to complete one if they want that. Despite all of this, most Americans have not done a formal advance directive. So there's different studies showing different numbers. If you are an upper middle class white person, the odds are more than 30% that you would have completed one. If you are a person in a non-Caucasian race or a lower socioeconomic status, it's much less than that. But the bottom line is 1 in 3 Americans have done a written advance directive. But the worst problem, because of those who have, it often does not answer the question. The first problem is that most who have done it, it's there in the hospital when you need it. And a study that looked at this broadly found that about 20% of those, that 1 out of 3 who did their advance directive, does the document make it to the hospital? And from a physician standpoint, I would tell you I'm very aware that the document is almost never there. We looked at that in our hospital, and that it was less than 10% of the time when there was a seriously ill person who said had done an advance directive, could you find it on the record? Most people haven't done it, and most who have done it, it doesn't get to the hospital. But the big problem than that is those who have done one, and where it did make it to the hospital, the paper itself very often does not answer the question, what do you do for Fred? It doesn't specifically take care of it. Well, I mean that. Well, let's look at Fred. Fred had done an advance directive. He said, as most do, have an end-stage medical condition or are permanently unconscious, and there's no realistic hope of significant recovery. And then there's a list of different things, and Fred had checked off, I do not want tube feedings given in that situation. But Fred with a serious stroke and high chance of disability, and yet it could survive this. He could improve. There's a chance he could recover his swallowing function. We won't know that for sure for weeks, maybe 6 or 8 weeks until now. Does checkoff that he did on his living will, does it apply right now? Is he permanently unconscious? Well, no, not really. Does he have realistic hope of significant recovery? Hard to know. So do interpret that. So the paper doesn't just fix the problem. I think the biggest problems with the living will paradigm, the idea that we're going to focus on the individual's right to put down on paper specific choices and lock it in so that we can be sure that they have their legal rights enforced. There's significant evidence base out there that that's not how most people think about these things. So of these, one of the largest studies was the support study. This was done about 20 years ago, and was a study that looked at a large number of people, something like 10,000 people who were seriously ill in the hospital, and a separate sub-study called the HELP study looking at hospitalized elderly patients. In these studies, patients were given the opportunity to have specific conversations with a trained person who could go through specific scenarios and have them specify what they want at the end of their life and complete a detailed living will or advance directive. This was done in these patients were asked this question: at the end of your life, if there are difficult decisions to be made, do you use this document to drive the decisions that are made, or do you want your loved ones, your family, and your physician to make the decisions? And most patients, 70 to 78%, 70% in the support study, 78% in the HELP study, said, I want my family, my doctor, to decide. I want them to make these decisions. When they thought that was just counterintuitive. What? You've just had this detailed conversation, you've written down what you want, and you don't want that to drive what happens? But that response reflects the understanding of these patients who themselves, they had been sick by definition. They're seriously ill in the hospital. A lot of them were really sick. In the support study, about half the people died within a year of the study. They knew how it really was in the hospital. Really hard. Things are better sometimes and worse sometimes. Things, nothing black and white. It's all odds and probability and trade-offs between risks and benefits. And there's different information from different doctors. Most people, 3 out of 4, they said, I actually want to lock down on paper now, or what might not fit exactly at that time. I want somebody that I love and trust, somebody with skin on, hear all that information, and make decisions. So the legal autonomy, individualistic focus that we've had initially doesn't fit for most people. Now, some people who very much do want to lock down in detail, specifically, this is what I want. And the living will kind of paradigm fits for those people. But for most people, it doesn't exactly fit. And I think that is a part of why 90% of people say it's a good idea to do this, but most have not gotten around to it. Most want someone else to help make those decisions when the time comes. So the second wave, sort of the paradigm shift then in advance directives, has moved from a living will, check off the form, nail it down specifically kind of paradigm, towards a high emphasis on naming your surrogate. Who is it that you want to make decisions for you, to speak to the doctors for you if you become unable to do so yourself. It's called the durable power of attorney for healthcare, or in the state of Pennsylvania, this is called the healthcare agent. So the healthcare agent is the person designated by the patient when the patient is able to do so, to speak for them in decisions if they become incapable. And the agent is able to make all the decisions that the patient themselves would make. It's not necessarily the person that you love the most, or your oldest son, or the daughter who lives in town. Your agent isn't a reflection of who you care about or who cares about you. It's really thinking, who is the person, really difficult thing, who hear complex medical information that's changed day by day, where it's odds and probabilities, where there's very often no certainty about what's going to happen. In a hard environment like hospitals and nursing homes are, different doctors coming and going, emotionally charged environment where somebody's so sick and people who care about this person in the bed are emotionally distraught. And whatever you say, there's going to be somebody who says, I can't believe you said that. Well, I love my mother. I would never let that happen to my mother. Someone who does this has got to be strong and tough and able to deal with complex information. Seeing who is that person and getting that down, and then talking to them, making sure that that person and your family, your loved ones, those who are going to be around the bed when you're so sick, they know what's most important for you, and that's the advanced care planning process. Unfortunately, most people have not named their agent. So for most people, when there are decisions to be made, I've got to talk to somebody to sort this out. Here we're looking at Fred. We have his living will, but we're going to have to interpret. We have to decide what fits now for Fred. For example, Fred has not done a named agent. Then we're into the health care representative. So in the state of Pennsylvania, the health care agent is the one who's been named by the patient ahead of time. The health care representative is the default maker, the default surrogate. And the health care representative is able to make medical decisions for the patient, but there are limitations to it. So, for example, if one is not in an end-stage medical condition, there's to the ability of the health care representative to decide to withdraw or withhold life-sustaining interventions. They can't just automatically make that decision. So it becomes kind of hard. Well, here's the list then, as generated by the legislature in terms of what should the default list be of who the doctors should turn to. First on the list is spouse or a child of spouse. Be a little, what is that? I'll give you an example of how to understand this. Let's pretend for a moment that many years ago, a total jerk. I was a terrible husband to my first wife, and she was a wonderful woman, and somehow we managed to have 3 kids before she threw me out because I was such a jerk. And my kids from that marriage, they hate my guts because I'm such a jerk. And so it's spoken to me for 20 years. Since then, I have reformed into the paragon of virtue, speaking to you now. And my current wife, and I love her so. And I come home and I say, I love you so, oh my darling, what can I do for you? And I tell her every day, I want you, oh my darling, that it ever gets so bad that I know who's there, that I can't be conscious or aware of who's around me. And unlikely I would ever get better than that. I really don't want tubes and machines to keep me like that. I'm ready to just go be with my God. So he knows what I want. And so imagine that I have my berry aneurysm in my brain, or I get hit by a truck, or I have something terrible, and lying in the hospital, profoundly neurologically impaired, unlikely ever to regain consciousness, hooked to a ventilator and feeding tube. I've been there long enough that doctors are needing to decide, are they going to go ahead and put in a trach? Are they going to put in a peg tube and then arrange for me to be moved to a facility for ongoing care? My wife is there and she says, no, he would never want this. There's only one problem. I forgot to name my agent. On my to-do list, I was going to do it, but I never got around to it. And so I am in the hospital with no healthcare agent. And so doctors are going to make this decision. They're going to the healthcare representative. Their representative is my spouse or adult child, not child of spouse. So if my 3 kids from previous marriage show up, the man is really bad and they show up at my bedside there in the ICU, if they say, we want you to put Dad on a trach and a peg, and the doctor counts 3 against 1, 3 say yes, we should commit to trach and peg, then this is what would occur. Maybe do that because they still are mad at me and they're wanting me to suffer more. Maybe doing that because they're very complex and they're sad and they're hoping there would be a miracle that I might wake up and they tell me that they forgive me or they love me or something. But the is, if it's the representative who decides, it could be that things would go differently from what I wanted. I don't have spouse or adult child, not child of spouse, then my adult child of current spouse speaks. Or down the list, down to the last on this list of healthcare representatives is adult with knowledge of patient wishes and values. So if I have no family or anybody, but my drinking buddy of many years staggers into the ICU and says he never would want this stuff, doctors can pay attention to a healthcare representative. Bottom line is, if you have not named your agent, it becomes uncertain what will happen and who will be the one to speak for you. So very important for everyone of all different ages to think about this and name their agent and document this choice of agent and have it witnessed and written down somewhere. And then talk to the agent, talking to this person that you've named about not a checklist of different tube and machines. Well, I do want dialysis, but I don't want a ventilator. It really is talking about what kind of living is okay for me. If, there's some people who would say if I'm alive, if I have any life, I want every darn tube and machine. Most will have some level where they say if living means this, that is permanent unconsciousness perhaps, or complete dependence on others, or various other levels of living, they'd say I wouldn't want to be sustained in that way. And if the one speaking for you has heard you say that, then when the time comes, the burden on them and the burden will bear afterwards in the years after that is much, much less. So this is the process of advanced care planning. It is so important for everyone to do. But there is a special population in your town and my town that are the ones most likely to be making these judgments over the next year, facing these hard decisions. This special population are those people with advanced chronic illness, people with pretty bad COPD or CHF or end-stage renal disease, the elderly, those who are living in nursing homes or assisted living. These are people where the answer to the surprise question, no, and the surprise question is, would you be surprised if this person died within the next year? This is a different question from, is this person terminally ill? That is, they know they're dying. Everybody knows they're dying. These people with advanced chronic illness, they don't think they're dying. They hope they live for years to come. They hope so. But sick enough or frail enough or old enough that it wouldn't be a surprise if they keeled over. And these are people where we need to do a special intervention to be sure that we get it right for them. These are people like Jack. Jack is a 91-year-old retired insurance agent who's a widower and lives in a skilled nursing unit. He's had really bad COPD, needs oxygen all the time, real short breath when he's moving around. Had some heart attacks along the way, had prostate cancer a few years ago, although it's pretty quiescent right now. He has one son who lives in Poughkeepsie. Jack had very meticulous guy, as a longtime insurance agent, and his son, who loves him so, really worked to do the right things about this. Boy, we want sure things go right for Jack. And so Jack had completed his living will years ago, and he had named his son as his agent, and signed into the nursing home, talked to them about the whole code status thing, and said, yep, I don't want to be coded. Don't believe in that. When my time comes, boop, that's it. I'm ready to go. But one night at the nursing home, the nurse was making rounds, looked in on him, and found that he was breathing in a bad way. He was kind of puffing with his breathing. And she flicked on the light, went over and looked at him, and he was pale, diaphoretic, weak pulse, low blood pressure. He looked pretty sick. So she went out and called the doctor. Now, unfortunately, it was the doctor on call that she reached. And talked about Jack and described all the vital signs: hypotensive, tachycardic, somewhat hypoxic. She said, dang, this guy sounds bad. What's the plan of care for this guy? I mean, this is an old guy with advanced disease. Are we supposed to be aggressive, or what's the plan? And the nurse looks through the chart and says, well, he's a no-code. Well, the doctor says, well, that doesn't answer my question. I mean, he's not in cardiopulmonary arrest right now, but, what's the plan? Are we to be aggressive? She said, well, here's a living will. If I am terminally ill or in a permanent state of unconscious, and the doctor, well, no, that, have you reached family? And the nurse, well, I tried calling the son, but I can't get a hold of him. He's not picking up. So what does the doctor do at that time? What would you do if you were the doctor? He says, gosh, this guy's super sick, but maybe it's reversible, maybe it isn't. We call 911. They send Jack out to the emergency room. And in the room, he has a chest X-ray that shows bilateral lobar pneumonia. And he's septic. His white count is quite high. And CO2 is climbing. He's in respiratory failure. He's getting ready to die unless he gets intubated. But an old guy with a living will that says, don't do stuff, and a no code. So the doctor says, are we going to tube this guy? And the nurse says, I don't know. I tried calling the son. I don't know. What does the ER doctor do? What would... Well, this guy's got a potentially reversible disease. We tube him, intubates him, and sends him upstairs. And the doctor puts him on multiple antibiotics and gives him every good treatment he can do. He's on pressors. He's on everything. And the next morning, the son gets the call. He races down to Williamsport, 90 miles an hour, from Poughkeepsie, walks into the ICU and sees dad to everything. And the son is just mad as hops and says, I can't believe you did this to my dad. This is exactly what my dad did not want. I'm mad at the ICU doctor. He's mad at the stupid ER doctor and that nurse out at the nursing home. And he's angry. He says, we tried to do everything right. He named as his agent. We did a living will. He was a no code. They tried to do everything right, but we, the medical system, got it wrong and did the wrong thing for Jack. Now, my question to you as you listen is, do you think that such things only happen in Williamsport? The obvious answer is no. It happens like this all over the place. I bet that if we went to your local ICU, wherever you live, and walked down the hall, you'd find a number of Jacks where we, medical system, got this wrong, even though everybody along the way was trying to do what was right. If we were going to keep this from happening, we would need a system to accurately document now the way the patient is, the way Jack is right now, what you do. Not some form like a living will that would be some future state permanently. No, right now, what are the decisions we should do about certain things? And would need to be actionable. You look at it and know what to do, right? Hey, there it is. That form would have to be accessible. It would have to be right there wherever Jack is, in the nursing home, in the ER, in the CU. That form is the POLST form. And so the paradigm, this way of trying to make sure that in the patients with advanced disease or frail states who are in the nursing home or whatever, they get it right. So there's a specific form that specifies specific actions or decisions. A, do we code him or not if he's in cardiopulmonary arrest? In a case of Jack's, what should we do? We do comfort care measures, that is, just keep me at the nursing home, keep me from having suffering here. I want whatever it takes, but I don't want to go out there. Or send him to the hospital, but just don't put me in the ICU on machines. Or do everything, send me to the hospital and give me the whole thing. Use of antibiotics, what about use of hydration or nutrition? It's signed by the patient or their agent. It's signed by the doctor, and it becomes an actionable order. It's a brightly colored pink form in the state of Pennsylvania. It's on cardstock paper. This travels with the patient wherever they go. So if Jack had one and fractured his femur and went out to the hospital, it would go along with him. And wherever he is, people look at the form and they know what to do. It helps. So there's not just an idea like the living will idea was 40 years ago. Seems like that's a good idea. Let's try it. This is something that has been established and used now for almost 20 years in some locations. So there's something like 15 states that are using it and many other states that are developing paradigm forms. We have the paradigm form here in Pennsylvania. And there's a very significant database proving that it does help. And it's more evidence than I have time to go through today, but if you're interested in looking at the studies showing that it really does help, you should Google POLST and go to the evidence or the research site. What this is that, number one, in cases where POLST forms are used, the likelihood that things will go according to what the patient wanted are high, 97, 98%, as opposed to the much lower rates that happen in environments where we don't use the POLST. This POLST form is not just a way to say, I don't want. It's not just a way of saying things that you decline. It's a way to titrate what you don't get, what you don't want, and what you do want. So, for example, in one study, when they looked at completed POLST forms, they found that of those who started the form, Section A saying, I want DNR, do not code me. They said elsewhere on the form, but I do want some more than the lowest choice. So I don't want to be coded, but I do want to go to the hospital if I get sick with something that's treatable, or I do want to have antibiotics for infection or whatever. And honestly, of those who started the form with a I want coded, almost said, but I don't want something else that they said I would not want that intervention. Really helps. But the POLST form has limitations like everything. So, first of all, it does not name the healthcare agent. The essential piece of advanced care planning for all of us, the POLST document does not do that. So it doesn't replace the need for an advanced directive focused on naming your agent. It complements it. And the importance of having people think about name their agent and then talk to the agent, that's important for everyone. And then the POLST complements that for this subpopulation. The POLST form is not an appropriate document for otherwise healthy people living in the community up and about. It's specifically designed for those that we had talked about, subpopulation. In the state of Pennsylvania, it's not immediately actionable out of the hospital or nursing home without a specific order from the EMS medical command physician. And so, for example, if somebody had a POLST form and they fall over at home and somebody calls 911, when medics show up, they can't automatically look at the POLST form, see the no code, and not do resuscitation. They have to reach their medical command physician and get his order. It is at home, and they do not want to be coded. The Pennsylvania out-of-hospital DNR, which is a bracelet or pendant around their neck or a piece of paper that specifies that. The biggest limitation for the POLST form is a piece of paper. And keeping in mind that the paper, not the main thing, it doesn't change what happens. The discussion, the consideration for Jack to think about what things do I want, what don't, and talking about that with his son and with those who are involved, that's the main thing. An well-done discussion where he can ask questions and process And then the document is a really important outcome of that discussion. So to lead that discussion, who can facilitate this kind of conversation? One of the biggest fears, honestly, that I have as a proponent of POLST is that if there's a medical system or a nursing home or someplace that says, well, that seems like a good idea, let's start that. Okay, we're going to start using that piece of paper. Jill, our mission clerk, we're going to start going through this on everybody getting admitted. Ask them questions, check off the form, we'll have the doctor sign it. If discussion is not well done by a trained facilitator, but who knows what you need to know to have this thorough conversation, it actually could make things worse, not better. No one can lead this kind of conversation and do it all the time. But there's a lot of evidence that if we wait for the physician to have a thorough conversation that's looking at the values that underline simple decisions, many people won't get this done. So non-physician facilitators who are well-trained and can spend the time going through these conversations and complete the form, the physician looks at it and signs. This is a way to supplement the conversations and documentation that physicians do. Training those facilitators is an essential part of developing a POLST paradigm, and that's beyond the scope of our talk today. Hopefully we'll have some future work helping for appropriate training for facilitators in the state of Pennsylvania as people are developing forms. So in conclusion then, we as a country have tried to answer the question, how do we get this right? There's been evolution from the initial legally focused, individualistic, living with checkoff form towards a high focus on having people identify who do they want to be their surrogate and to their surrogate and document who it should be. And those who really do feel very strongly about specific interventions. There are some people who say, I always want to have tube feeding as long as my gut would absorb it. Or I never would want to have this intervention. I don't care what anybody else says. Some people really do want to lock that down. And so having an advanced directive document that allows that subgroup of people who want to be very specific about these things, what's good for that subgroup. And having the subgroup of the frail elders and the people with advanced disease has systems set up for deep discussion and then meditation using the POLST form. That's a really important step for that group. So naming their agent, sort of a two-phase process, and that subgroup having the chance for a POLST conversation. Now the real question is, who will work on helping to make sure that there's a system so that we can get this right in your hospital or health system or nursing home or community? The sense is that the 100 of you who are listening to this call are very likely to be the ones to make sure that such a system is created, so that we're sure that we get it right and that we don't do the wrong things for people like Fred and Jack. Now I'll end with just a confession, and my confession is that Jack, the picture Jack that we looked at, he's father-in-law. He lives in a community in Pennsylvania that is not using the POLST form. They're just not familiar with that just yet. The story I told you about Jack ending up on the ventilator, this is actually an amalgam of true cases that I have had just like that. But that isn't the true ending of the story for Jack. But worry about it, in that if he's in a place where there's not this system created to make sure that we get it right, Jack has actually filled a POLST form out. As I've talked to him about this, he said, I want to fill one of those damn things out. We did. In a medical community, Roman hospitals where they're just not that familiar with this. So I don't know that that would be honored or understood. The likelihood of Jack getting what he didn't want worries me as his family member who cares very much about him. In his community, as others are in the state of Pennsylvania, the work that you all will be doing going forward to make sure that this gets implemented, reduce the risk of bad things happening for people like Jack. Thank you for listening. That's what I wanted to say, and then I think we have a few minutes for questions.
All right, thank you, Dr. Nesbitt. We do have several questions that have come in from the audience. I did just reiterate that Marion's email address is PAPOLST, P-A-P-O-L-S-T at Verizon.net. So for any of you that we don't get to your questions today, please submit those to Marion and we will get those answered for you. Our first question from the audience today is, how do health systems that use EMRs handle the paper pink cardstocks or the POLST form?
It's a really good question, because what we're talking about is in our fragmented healthcare system, we have different homes and different hospitals, each of which is a silo, and patients move from silo to silo. And often, if we do a really good thorough conversation in one of the silos, patient moves, they're starting all over with new people, and they just don't know what has been discussed. And so the POLST form has been a way for us to try and make sure that something travels with this patient from place to place. But I will tell you, the experience here, as in many other places, is it's hard to get that perfect. To make sure that, for example, if Jack fractures his femur and the POLST goes with him from the nursing home to the hospital, that was discharged from the hospital, that POLST will come back, or if a new POLST is generated, that will actually make it with to the nursing home. The ultimate fix for that is to have a coordinated electronic medical record. So I will tell you what we've done in Williamsport. In Williamsport, we have an electronic medical record in our health system, Susquehanna Health, and have created an icon, an advanced care planning icon. And on the icon, when you click it open, any advance directive, whether it's a living will or a healthcare power of attorney, be scanned in on that site. The POLST that has been done is scanned in on that site. And we have created a system so that if a POLST is completed in the nursing home, we have granted access for them to get that scanned into the EMR for our health system. And in nursing homes, they have the ability to pop open the EMR and look at that icon to see. So our hope here is that this will decrease the chance that if a piece of paper goes missing, that the critical information will not be available for those who are giving care in the different environments. And I know there are other systems that are working in the same way. So that's one answer to your question.
All right, just a reminder to folks on the call, you can post questions to Dr. Nesbitt using the chat function built into the webinar, and I can relay the questions to him. So the next question we have from the audience today is, in Pennsylvania, can nurse practitioners or physician assistants sign the POLST form?
That's a very good question, and this is different from state to state. The paradigm form in Pennsylvania is a form that can be signed by the physician or practitioner or his assistant who is primary clinician taking care of that patient. So any signature of those would work.
All right. Next question. Question from the audience. Where can the POLST forms be obtained?
So what I will do when we're finished, right now the POLST forms can be downloaded from the SOL site. I think when I'm done, I'll ask Marion to get on and get information in terms of how people can access the forms. In our region, we have downloaded the initial forms and then print them according to the specifics locally. So it's essential that the form be the pink color that's identified and that it be on the proper cardstock paper.
Dr. Nesbitt, this is Marion. Any user can go to the POLST website to access the link to download the POLST form, both in English and a Spanish version. So the best way, it's a very long website, the best way is just to Google PA POLST, and you'll be able to get to the POLST website easily from there.
Good.
Okay. Next question. Do healthcare institutions follow POLST obtained from other states with similar documents, or is this defined by the institution's individual policies?
Yeah. So it is defined by the institution's policies. For example, if a POLST document is generated out of state, but even within the state in a different town, or even within the town in a different healthcare institution, does the hospital obey the directive on the POLST form? So I will tell you that's quite institution specific, and as we integrated this into our health system policy is that the form is not an automatic physician order on the hospital system. It is automatically incorporated into our record. The physicians will look at it as they're writing the hospital-specific orders. So, for example, if somebody comes in with a POLST, that does not serve as their in-the-hospital DNR order. That order needs to be written by the physician in the hospital, the attending physician in the hospital. But I will tell you that a POLST form coming in from elsewhere, whether it's from outside the institution or outside the town or outside the state, POLST form is a documentation of a deep conversation, expressed decisions on the part of the patient, and is a very helpful thing for somebody who is seeing the patient for the first time. Very often in our fragmented system, a hospital doctor is seeing somebody they never have seen before. And if the completed POLST, it's very helpful in terms of writing the orders that match what that patient wants during that hospital stay. But exact policies on that are institution specific.
All right. Next question. Is a copy of this form as valid as the original, or is the original required to follow the resident wherever they are transferred?
Right. And so the paradigm is that the original would go with the patient wherever the patient goes. Now, let's tell you that in real life, that's hard to make that happen. And a copy of this form, and we've really pushed to make sure that copies, that we keep them pink, because paper disappear into the morass of paper charts, as you know, and a part of the effectiveness of the POLST is to be able to immediately find it when you need it. So we do have systems where pink copies are kept. For example, if a nursing home sends somebody to the hospital, they'll keep a pink copy on the nursing home chart and send the original. I know that in some places, certain institutions will keep the original and send a pink copy. And, that is considered valid. Mary, have any other comments on that one?
No, I agree with what you stated.
Okay.
All right. We had a few people ask. We are going to be providing today's PowerPoint slide on the PA POLST website next week, as well as a recording. So I just want to reiterate that. The next question that we have from the audience: can the POLST form be completed via a phone call to the family member like a verbal order, i.e., without the next of kin or power of attorney actually having to sign the POLST form in person?
Yeah. So that one is a very important question. It's a good question, and what I can tell you is that the form is legally completed when it's signed by the physician, nurse practitioner, or PA, and the patient or their family member. In real life, sometimes you can't get them there to actually sign the form, for example, before somebody is going to go from here in the hospital to the nursing home. Gosh, we're going to discharge the patient in an hour, and having the conversation, patient can't really completely participate, so I've called the daughter. We've gone over the form. We've had a thorough conversation. I scribed the form for her. I have signed my part. I will let the daughter know that I'm sending this form with mom out to the nursing home. It's really important that when you can, that you sign that form. And again, I suspect there are institution-specific policies in terms of whether they fix a form to somebody to sign or just have it there and have the person sign when they arrive. I'd think of this as there's a legal level of how this form is used, and there's the real-life level at the bedside. in terms of what action is taken. And if there's been a very thorough conversation, it's thoroughly documented, and the signature is not yet on the form. In most environments, those who are doing the care would proceed with the decisions that have been documented.
This is Bob Wolf calling, just to add a comment there from the legal side. There is no statute in Pennsylvania that says that you must have a patient or a patient representative sign the POLST form for it to be valid. It doesn't mean that you shouldn't always do it where it's possible, but there is a statute that says you can't do it in the way you described. So you ought to do it the best you can, and that's exactly what you described.
Thanks. It's really important because I have realized that I think a part of what has slowed down our ability to make sure that we're carefully getting things right is a strong focus on legal things. For example, for many people, as I've talked about completing advance directives, and somebody who says, oh yeah, it's a good idea to do it, but I've really done anything like that. Sometimes when you ask, well, why is that? What's come up with that? Their sense, well, I haven't gotten in with a lawyer, I'm not able to afford, or I'm kind of scared about these legal documents. The legalities can sometimes make people afraid to step in and do what is most important, the talking, the real conversation, the documenting what the person wants. And again, I'm a doctor, not a lawyer, and the legal parts are super important, but the most important thing is that we do the right thing, understand it, document it, and then make sure we can carry it out.
All right, question from the audience, and this might be along the same lines. How will this affect individuals who are no longer able to complete the POLST form due to the advanced stages of dementia?
So I'll tell you that when conversations about what is to be done if we have a patient who is not able to make decisions on their own and we're needing to make decisions, we sound then with the surrogates, the family, the loved ones, and decide what treatments match what is to be done. And hopefully, if the patient has identified their agent, and the son that I'm sitting with is a legally defined agent, then the son can speak for all of the decisions as the patient would if he were competent and can complete based on that. It's hard if the patient has never identified an agent, and so we're making decisions based on what would be the patient's best interest, including all the family members, if none is legally empowered to speak and automatically say. I'll tell you in real life as we do that, if we're dealing with healthcare representatives, it's really important that we get everybody who is involved with that patient in that conversation and decision all working together so we're sure that we're all coming up with the right thing. If there's contention in that situation, there's no agent, and there's sons who are arguing about what's to be done, then we need to sort of default towards the more aggressive intervention. Once all of that is worked out, then we complete the POLST form.
Okay. Next question is, does the Pennsylvania out-of-hospital DNR order still have to be done with a POLST?
Yeah, an excellent question, and I must tell you right now, in this time in Pennsylvania, when the POLST form isn't recognized as a valid physician order outside of hospitals, and there's a different document that is one that's recognized. So I struggle with this every time we're going to send somebody from the hospital to the nursing home. We've had a thorough talk. We've documented on the POLST form. The person says there's no way that I want to be coded, and we've got on the POLST form, and then we're going to send this person by ambulance to the nursing home. And if the person happens to go into cardiac arrest in the ambulance, does MS have to code them, even if they're looking at a POLST form, because we did not complete a second document, the out-of-hospital DNR form. In our area, we've done a workaround with that, so we've worked with EMS, and if they know that there's a POLST form, then the EMS drivers who are going to be in the ambulance, all the EMS physicians say, I have a POLST form here, it says DNR, can I have your order for that? And the doctor is sure. Now they have the ability to not code the person even without a separate document. But we've worked to not have families complete two different sets of documents. it's different if somebody's going home and staying home. In a situation, they really do need to have an out-of-hospital DNR document. So, for example, in our hospice, we're very careful to try and make sure that that document is what's in the home.
All right. Next question. What if the POLST was created and signed in another state, New Jersey, for example, but the patient has come to Pennsylvania for care?
So the best thing, I think, is to take that POLST form, who's going to be providing care for that individual, to take that POLST form, which again is a reflection of thinking about these things and documenting preferences. And this then is a helpful stepping off point for completion of a POLST form. And again, Bob would know the legalities about this, but in real life I will tell you that if we say we have this New Jersey form, it says that you would want this and that. Is that right? Let's go ahead and complete a Pennsylvania form and have it signed so that we have our form. But Bob, have a comment on that?
Well, when you get in between states, it gets to be more difficult. Basically, any indication that authentic of a patient's wishes with respect to medical care ought to be respected as far as possible. However it's given, whether it's orally, whether it's in a piece of paper, whether it's a POLST form or otherwise, where you have people who have more than one state with connection, and increasingly have that with snowbirds who are just coming back to the Pittsburgh area, you have to think about, do you need documentation in more than one state? I had people in yesterday, talk with them for a couple of hours, because we had to do Ohio forms and Pennsylvania forms of healthcare powers of attorney and living wills, and I talked to them about a POLST. Pennsylvania has a POLST, Ohio doesn't have a POLST, but there are a few people who are using it. So, you really want to, where there's more than one state, you'd want the person to take that into account. But no system's going to be perfect, and if you have something from another state, whether it's an advance directive or a POLST from another state, it has to be looked at, but no document is a substitute for thought, expertise. The physician that's doing the treating needs to look at the document, whether it's a POLST or an advance directive, read it, try and understand it, and apply it sensibly using their experience and expertise.
Thank you. We have time for one question. The last question is, can you elaborate on the proposed training for facilitators who present and discuss the POLST, and where does someone go to get this training?
Yeah, a very good question, because again, the discussion is the core piece of this, and having trained facilitators is essential if it's going to be a good quality discussion. What I can tell you is there's various approaches to this. Some very good established systems. So in La Crosse, Wisconsin, the Gunderson Lutheran system has created the Respecting Choices curriculum with a very thorough preset training for facilitators. And we used that as we start our project here, and it was utterly invaluable. There are also places where there are locally developed training programs. So, for example, in our community now, we have regular training 2 or 3 times a year to train facilitators at different nursing homes and hospitals. There's a group of us who are working at the state level to try and help develop a curriculum for training facilitators. A facilitator, to have this conversation, you need to have some medical knowledge, so it doesn't have to be a physician. It could be nurses or social workers or others, but you have to have specific knowledge about, for example, the odds of successful CPR and certain other things. It needs to be somebody who's able to talk to a small group, even if there's emotion in the conversation, and be able to approach it properly. So this is both intellectual understanding of the issue involved, but also communication skills. So we're working on helping to create tools that would allow for trainings in different places around the state. Do you have comments on that, Marion?
Yes. There are tools available at this time, though. Again, if you go to the POLST website, examples of something that might be useful to those who are having a conversation is the guidance for healthcare professionals that you find there. There's FAQs there. And there's also information on how to have this important conversation. So I recommend you take a look at that website.
Right. Well, I just wanted to let everyone know, thank you very much for joining us on the call today. We did have some questions that we were not able to get to during this session, so please keep those coming. Email them to Ms. Marion Kemp at PAPolst@verizon.net, and you can also Google the website. Just Google PA Polst, and that should come up for you. Mary, anything you'd like to add?
Yeah, well, I would like to comment that one of the useful tools that you'll find now on the website is the POLST in Action in Pennsylvania video. So take a look at that. Now that we've come to the end of the webinar, I'd like to thank all of you who participated. We really appreciate you spending the time with us today. And I especially want to thank Dr. Alex Nesbitt for all the important and useful information he's provided to us. Thank you.
All right, thank you, everyone. And again, send us those questions, or if you had any other comments, please feel free to send them on to us. Again, the presentation and any handouts, a recording of today's webinar will be available on the PA Polst website by the end of next week. All right, thank you, everyone. Have a great day.